Good afternoon.
Good afternoon.
Welcome, everyone. Wow. I tell you, the saying that I've been on skates all day is real. I'm still on skates. My name is Anne Marie Burton. I'm the Vice President of Programs at the Congressional Black Caucus Foundation, and I am so excited to have this fantastic panel on mental health. How many of you attended the health and wellness session yesterday? So, for those of you who didn't, please check my Twitter. I have highlights on what the Surgeon General talked about regarding mental health and the disparities that we continue to face. When we were brainstorming this session, full credit to my partner in crime, Charles Ellison, and Kimberly, this was such an important topic in terms of just the treatment, and I was so excited to hear the Surgeon General emphasize this as one of their strategic pillars and things that need to be addressed. So really, I'm not kidding when I say check my Twitter, because you can really see what he talked about and the interventions and what we need to do as a community. But I won't take long because I know we are all here because you're very interested in the same subject that we are. So I want to say thank you for being here. This is a collaboration, and I'm excited that we were able to pull it off. I know that these seats will be full in a few minutes as soon as the other session lets out, but you're in for a treat and a really informative discussion. And with that, I'm going to introduce my moderator for today, Mr. Charles Ellison.
All right, good afternoon, everyone. How are you all doing? All right, great. My name is Charles Ellison. I handle strategic communications, external relations, media relations, all the like for the Greater Washington Urban League, so I'm essentially their communications director. I am also principal and chief strategist for BE Strategy, which is based in DC. I am also a jack of many trades. I do a daily public affairs program on WURD radio in Philadelphia, which is the only black-owned talk station in the entire Commonwealth of Pennsylvania and one of 3 of its kind in the entire country. They are our official media partner, and proudly so, to help facilitate this very important conversation on mental health. So before we kick off that conversation, first, just a little bit of housekeeping. So for social media, if you'd like to join in for a social media conversation and you'd like to present questions as the discussion is happening in real time, go to hashtag CBCFHealth, hashtag CBCFHealth, particularly if you use Twitter, and also hashtag Black Mental Health as well. That's WURD. But we will be monitoring hashtag CBCF Health and hashtag Black Mental Health to facilitate or funnel any questions to us, the panelists. Also, in your chairs, you might see little note cards. Those are cue cards. Please write down any questions or comments or feedback that you might have, and you will see some young professionals who are going to be circulating, these very talented sistren over here. They're raising their hands right there with the Greater Washington Urban League, and led by Ashley Mason, who is the senior marketing strategist for the Greater Washington Urban League. So hand your cards to them, or kind of motion to them that you have you want to get a card to them so you can have questions asked during the event. Also, you can email as well. C. Ellison, CELLISON. I'm not related to Keith Ellison, by the way, but C. Ellison at WURD radio.com. We will be monitoring those 3 tools to facilitate questions for the panelists as we carry out this discussion. So let's get this started right now. I'd like to first, before we do start with our keynote panel in our main presentation, we're going to have a very quick, about 15-minute fireside chat with Kimberly Corbin, who she's going to be moderating this portion, so she's going to take it over. Kimberly Corbin is the Chief Administrative and Financial Officer for the Greater Washington Urban League. So Kimberly, raise your hand. All right, great. Okay, so we have a very special conversation that's about to take place with Dr. Alpha Stewart. Dr. Alpha Stewart is the president, the newly elected president of the American Psychiatric Association. That is the lead organization, umbrella organization for psychiatrists throughout the United States. She's actually the first African American who's been elected to that position. Give a round of applause. I'm sorry for that. I'm not going to talk too long. That's a 171-year-old organization. Right. let me let Kimberly's going to talk all about it. She's going to tell you all about it. I'm still amazed by that. But she's going to have a great conversation with Dr. Alpha Stewart. Go to @Dr. Alpha Stewart for her social media. And once again, #CBCF Health, #Black Mental Health. If you'd like to ask questions, I'll let Kimberly start the conversation.
Yeah, Charles was trying to steal my comments and my questions. I'm like, can't steal them. So let's just say this. I am extremely honored, first of all, to be on this panel. It has been for the CBCF and for the Greater Washington Urban League. It has been for the CBCF and for the Greater Washington Urban League. This has been a blessing. We have been, I think, both of the organizations have been looking to seed and looking to bring this brain trust together so that we can move our community in a different direction, one that is of healing and towards healing for Black community as relates to mental health. So to be sitting next to Dr. Alpha Stewart and on this panel with all of this brain trust, I got goosebumps. And we prayed it in first. So I'm a woman that just likes to get down to it, and I know Dr. Alpha Stewart is too. So first, let's just say I'm honored, and I think we've already given you a round of applause, but it cannot be enough. I really want to understand from you, how the heck okay, let me give me my Harvard voice. How did the circumstances of this day allow your gifts and talents to take over a 174-year-old organization that has a difficulty with diversity and, in your own words, has a challenge with dealing with the racial issue, discrimination, that has a challenge with ensuring equity and healing for the Black community? How did you get here?
I've never been at.
You on?
I don't know.
Here. Just take mine.
I've never had that question asked that way before. First, good afternoon, everyone. It is, I'm sorry, I got goosebumps there for a minute, because as you were asking the question, I was thinking, shoot. How on earth am I going to answer that? Because that's one of those compound statements for you Harvard-trained people. It is my honor, really, to be here and to look out at all of your faces and to know that this is a historic moment in the history of the CBC Foundation. To have a specific mental health focus means that the hard work that goes into people like me doing what we do, and there's several of us on the panel, pays off when we get to do this, to bring this message to you so that you can use what we know to help improve the quality of life and mental health and well-being for people that look like us. So I just want to start off by saying how appreciative I am of you all. So give yourselves a hand. And that was to stall for time to think of an answer. So, yeah, the one I can actually say, because that's a whole other girlfriend over drink conversation. Yeah, we'll set that up. Let me try to answer it this way. You may not know this, but if you hear it in my voice, I'm from the South. I'm from Tennessee, and I grew up in the 50-ishes. after Brown, I grew up in the South after Brown v. Board of Education, still in segregated, systems in Memphis, Tennessee, where Martin Luther King was assassinated. So I came to this profession with a lot of stuff on my mind as it related to what causes stress and unhealthiness psychologically in Black folks. Just the presence of being in America as a Black person, James Baldwin says, keeps you in a state of constant rage. And so the inherent nature of my desire to give back as part of my upbringing led me to medicine and ultimately to psychiatry. And looking back on it, and every now and then I have an opportunity to reflect, and looking back on it, it is clear that I had no great design to become one day president of the APA. That was not on my check this off because you've done it list. What was on my mind was when I had the opportunity, that I should take full advantage of whatever came my way to be somebody who could make a difference and make an impact as it related to what interested me in the field of healthcare and medicine. And that chance came a few years back when it became clear that there was a slight change in what we call and I say this publicly, so even though it's being televised and will be heard all over the world probably, that the APA as an organization of pale male frail men was not going to survive. Mm-hmm. And in that way, and that there were opportunities with the nationwide move for diversity, equity, and inclusion, there were opportunities afoot. And that some of us needed to be prepared, because it's not like no one who was Black ever ran for president. It was that no one who was Black ever was elected president. And we know what elections can result in. I'm just saying. And so there were several of us at the time who began to think about how to do this. And anyone who's ever run for office knows you've got to have a base. You got to have good supporters. You got to have people who are willing to speak on your behalf, because you can't be everywhere. And you got to have a message. I see you have the message that I gave at our opening session, where I think many people were surprised that I actually said out loud, we have got to get to the forefront of the battle against discrimination, implicit bias, those things that are unhealthy psychologically for large populations of people. I said that in my opening statement after I became president at our big meeting. There were people in the audience who were surprised that I was that direct, but I'm from the South and we just met, but I think you kind of got a sense that I don't hold back a lot. I carry a Medicare card, so I've lived enough. I've got some good life experiences to look back on. I've done more than most little Black girls who grew up during my time in Tennessee ever hoped to do. I've traveled. I'm educated, not at Harvard, but I'm educated. And so it became clear that someone was gonna take the plunge. And there was some general agreement as to who it should be. Interesting story, though, that didn't make the press is that they ran 2 Black candidates. Ultimately, the APA was going to have a Black president. In this election cycle, there was going to be a Black president. I was fortunate and commandeered support across several different segments of the population, and I have a pretty strong history of working in organized psychiatry. I've been president of the Black Psychiatrists of America, the Association of Women Psychiatrists. I was president of our foundation for the APA, so I've got some street cred when it comes to managing and being in control, because that's really what I aim for, to be in control of things. You want something done, you got to control it. Y'all know what I'm talking about.
So let me ask you, so you said it. You like to be in control. Mm-hmm. Okay. So from an outsider's perspective, from a community organization, not from the professional field, it clearly looks like we have lots of policies and we have lots of funding from the alphabet soup, DOH, HHS, NIH, and we can go on and on and on. So we have those policies, we have a budget, but where's the system of health care, because it doesn't seem that the policy is translating into healing action in a cohesive way.
That is very well stated, and I'm glad that I'm asked this question in the midst of a meeting convened by people with a legislative foundation, because the policy resides in the hands of the people who make policy. The people that we are all here meeting and networking and speaking to are the people who have ultimate control over those things that wind up being the policy. Everything from the policy of how many times you can be seen by a doctor, whether or not you have parity with respect to, we passed a law, will be 10 years now, almost 10 years ago, we passed a law that said there will be equal parity between physical and mental health. Everybody has to do it. How many of you who may have had a need for yourself or a loved one to seek mental health treatment have been told by the insurance carrier at your job, well, we have a network of people that you can see. And then you start calling, they don't see you, they have a waiting list, I'm sorry, we don't take that insurance anymore. That is not parity. And so the people who make the policy, who need to be advised that the policies that are in place aren't working, some of them are right here in this building today. Some of them work with the other people who have unfortunately been in the position to hold up progressive policy when it comes to health care. Our voice collectively as a group, as a population, has to be loud enough, strong enough, and informed enough to make people pay attention when we say, I got a good job, I got good insurance, my child needs some help, and I can't get a child psychiatrist because there are none on your panel even though you list these names. Do something about that. Talk to your benefits officer. Don't go back with that insurance company. There are a whole host of things that can be addressed on this policy tip that we aren't knowledgeable enough about how to attack these things. I hope one of the things that we sort of trigger in your minds is getting informed. If you work somewhere and you just randomly go through, whether it's a primary care doc, OBGYN, a surgeon, a dentist, or a psychiatrist or psychologist, and you start calling people and you can't find anybody on that list who will see you if you need it, that's got to be reported to somebody. Somebody's got to be held responsible for that. And I can't do anything about changing that policy because I'm up there advocating on the Hill for better policy too, for everybody with a mental illness, for everybody who needs treatment, for all the doctors who provide the treatment, psychiatrists, psychologists, social workers, and others. But on an individual level, that's where the policy issue has to be fought.
So when you talk about being informed, I'm just going to rattle off DSM-5.
Yes.
So can you inform us on where the history, or not the history, but where the DSM-5 is going? Because you have an opportunity to influence.
I think influence and control are different, but I'll take influence on the way to control.
Okay.
DSM-5, for those who aren't aware, DSM-5 is the manual, we call it the Diagnostic and Statistical Manual. It's in its 5th edition, and it is the construct that we use to assure that there is some level of objectivity in making diagnoses. It is not without its challenges as it relates to populations of color, people who live on the fringe, people who are marginalized and disenfranchised, and who live in circumstances where they live, work, and pray impact greatly everything else that happens to them psychologically. And we recognize as a profession that this is an imperfect tool, but over the last, 10 years or so, there have been a few things done that are at least moving us in the direction of having a better handle on how to make this useful in the lives of people like you and me. One was the development after a long battle, and I will say that there were some real champions inside the organization who fought very hard to make sure that culture became part of that construct that was used, that we are not all kind of same milquetoast, one-size-fits-all kind of people when it comes to our psychological wellness and identifying illness in a psychological framework. And so there was a large group of people who put a lot of effort into pushing to have what is called the cultural formulation in the DSM-5. And with it, you are required to use a framework that is designed to address cultural difference, cultural uniqueness, cultural specificity along a continuum in order to make a complete and accurate as well as best you can diagnosis. So there is that has happened over the last 8-10 years. In its most recent version, we've actually begun to introduce things that we know are more relevant thanks to some of the work done by folks on this stage that you're going to hear from today in the field of psychiatry and psychology around the impact of racism, implicit bias, living in impoverished conditions, not having access to proper nutrition and recreation, all of those things that we know impact on one's overall health. And most importantly, and I think perhaps most relevant in terms of some of the discussion we're going to have today, the impact of trauma and violence, individual, interpersonal, and community experiences of these things are now being factored into the diagnosis making. There's a whole new area of discussion around the impact of trauma from childhood throughout the lifespan.
Let me ask you this. This is perfect segue for something that is
good.
Yes, perfect segue for something that I think we grapple with in general. Talk to us about the difference between this debate between biological and trauma influenced mental illness.
Well, I'm not sure if biological means things that are a part of our DNA and the way our brains develop just naturally from birth, if that's what you mean by biological versus the trauma that we experience in our daily lives in an ongoing way, kind of stress on steroids. Just being black in America, being black and living in certain neighborhoods and conditions, having no access to certain kinds of educational employment opportunities. If that's the dichotomy that you are, see, I got some Harvard words too. If that's the dichotomy that you're aiming at, then I think from the standpoint of how we use our diagnostic manual to incorporate our understanding of what people come in and tell us is going on in their lives, it means that using something like the DSM with that cultural formulation and training psychiatrists, not just black psychiatrists, but psychiatrists to understand the impact of discrimination, racism, implicit bias, sexism, homophobia, all of that stuff, that the more we can train everybody who provides service. There are not enough black psychiatrists in the country to serve the needs of every black person who needs them. There are about, 2,000 of us? Yeah. We got a couple of thousand people for a population of people in need much greater than that. Same numbers percentage-wise for psychologists. Social workers probably have more, maybe 4 times as many. But from the standpoint of providing professional care, good quality professional care with a mindset towards I understand the circumstances from which you come and how that impacts on your psychological wellness. We just don't have enough of us to do that for y'all. There just ain't enough of us. And the pipeline is not filling up fast enough. Although I will say in this setting, if there are people in here who can encourage young people with an interest in the STEMs, science, technology, engineering, math, and all of that, if you know people, encourage them. Medicine needs their voice. They need their presence. And we just don't have enough of them in the pipeline to take over when folks like me are ready to retire. I told y'all I got a Medicare card. I ain't that far away. But from the standpoint of how the DSM handles that and what we can do with that, I think it is incumbent upon people who seek mental health care to understand going into this that it is, in fact, things that have happened to us sometimes long before we realized it that are impacting. Dr. Newton has a wonderful book on the continued influence of slavery on our psychological well-being, post-traumatic slavery disorder. So there are things that we are hesitant to talk about in the Black community that we need to begin to share. We get depressed. We are committing suicide at alarmingly high rates. We do suffer serious anxiety disorders. We do have those illnesses that impact on one's ability to function, to have good relationships, and to lead a healthy and productive life. These are not myths that only white people get these diseases.
So I know they're gonna give us the hook in a
We
minute.
gonna look.
We ain't gonna look. But I'm gonna get one more. I'm gonna get two more questions in.
Okay.
Okay. This last one.
Next.
Until we talk to you. Suicide
Yes.
definition. I think when we consider the self-neglect that happens in some part of a traumatized person, we don't consider that necessarily as suicide. So when you look at, I think it was the CDC had the line of Black suicide, it's flat. But that's not what we are experiencing as a community organization or in our own families. So help me understand what we need to do with this definition of suicide so that we are catching it before it happens.
Let me just say for the record, publicly and with the full knowledge that as the president of the American Psychiatric Association, this will be quoted somewhere in social media today. Anybody who shows you a graph that says Black suicide is flat is showing you bad data.
Yes.
Hallelujah. Okay, let me just say that for the record. And the reason it is bad data is because in the African American community, there are three things that we typically do not talk about outside of the house, outside of the family, to anybody who calls and says we're doing a survey on Black suicide.
First of all, never answer the call.
You may not answer the call, but you might be one of those people that says, well, the phone hadn't rang today, so I'm going to see who this is. We don't talk about child sexual abuse and human trafficking in children. We don't talk about the kinds of things that we would define as mental illness generally in our family. Remember soul food? Mm-hmm. And who had the answer to the family's problems? Okay, Uncle Chester, Charlie, Sam, whatever his name was, upstairs with the money and the TV that didn't work, and everybody thought he was just crazy because he was just watching a TV that didn't work. He knew what was there. Now, he may have had a mental illness. I'm not going to deny that. But he also had good sense. The third thing we don't talk about, and in the face of so many people who have committed suicide, taken their own lives with the full knowledge that they felt there was no other option, is suicide. We don't talk about those things, so you can't get an accurate reporting of anything that you're not talking about. No one is admitting that someone in their family committed suicide. If I ask you, any suicide in your family, I'm doing a history. Any suicide in your family? No, ma'am. Anybody in your family ever been depressed? No, ma'am. Anybody in your family ever been abused? No, ma'am. We got to talk about this stuff, folks. I thought that Don Cornelius' suicide was going to bust the cap on this. I thought we were going to be talking about it everywhere. For about 5 minutes, we did.
And then left alone.
Young man, the young actor who was on the rise, Lee Thomas Young. Yes. I said, well, young man did it, millennial, up and coming. That's going to get a lot of traction on social media. No, 5 minutes. If we don't start talking about this stuff, it's going to continue to be underreported. The policies that we need to have in place to provide the services through programs and funding will not be funded because they'll say, hey, y'all ain't got no problem with suicide. We ain't giving y'all no money for suicide prevention. Churches don't talk about it. Families don't talk about it. Folks in the community don't talk about it. If anybody in here has had a family member, a loved one, or someone that they just knew from the neighborhood who committed suicide, think about how many times you've spoken about that with anybody. And I'm willing to bet 0 to 0, maybe 0 to 1 with the person who told you they committed suicide. And that was the end of it. We have to dispel this myth that mental illness doesn't happen to us, that it's a white folks disease. We are suffering in silence and pain.
So, first African-American president of the American Psychiatric Association. What's your vision?
I just
Short.
I don't do
Three.
any I don't do
Summary.
anything short.
1, 2, 3. 1, 2, 3.
Educate, inform, free your mind from the myths that are holding us back. Get educated, and don't just read it on the internet. Talk about these things. Make a statement somehow. Everybody in here on social media needs to what is it, hashtag?
Hashtag.
Whatever that hashtag was that he
CBCS
said. Everybody in here needs to make a commitment to put something out there that says, we can work on this, folks. The black community can work on this. We can do better. Identify the people in your community. We've got national organizations represented here. Black Psychiatrists of America are here. Association of Black Psychiatrists are here. We got the big organization for all of the 37,980 psychiatrists that are members in the country and abroad. We've got people out there, but if you don't talk to them and force this issue into the mainstream, it won't happen. Was that 3?
That was 3.
Okay.
Thank you.
Thank you.
So, Dr. Alpha Stewart, thank you so much for sharing all of that. You get to hear some more. I'm going to move out of the way and allow Charles Ellison to actually expand this conversation to the entire panel. Thank you again, Doctor.
Thank you, and thank you all. Thank you. Thank you.
Okay, thank you, Kimberly Corbin, Chief Administrative and Financial Officer for the Greater Washington Urban League. Fantastic questions, fantastic job. That was a very delightful, very insightful chat with Dr. Alpha Stewart, who's going to remain on the keynote panel here. We have our keynote panel here. I'm going to introduce them very shortly, and also our adjunct panel here as well. We are monitoring social media very closely, hashtag CBCF Health and hashtag Black Mental Health. Definitely, you can start throwing questions at us now at this panel. Also, you have cue cards in your chairs. Everyone should have a cue card. Please write out your questions, hand them to Ms. Mason over there in the yellow shirt, and also Ms. Anderson. Ms. Anderson is somewhere. There she is. Okay, it's just, she was like the Matrix, like Mr. Anderson. Like she just was there and then she disappeared. But so definitely hand your cue cards to them. They'll be circulating the room. Or C. Ellison at WURDradio.com as well. Delegate Angela Angel, if you can join us here on stage. These two young ladies over here, these two young sistren right there. Thank you. And they'll make sure that it arrives to me, and we'll be throughout. This conversation is going to be somewhat non-conventional, untraditional, in the sense it's going to be very organic and free-flowing, a bit of a freestyle session. We want to make sure that we try to absorb as many questions or comments as possible, so that's why we have this new sort of digital interactive format for you today. I'd like to introduce Dr. Patricia Newton. She is the CEO and Medical Director of Black Psychiatrists of America. That's at BPA Inc., is that correct? BPAIncPsych.org. Right, BPAIncPsych.org for more information. She's going to give a very brief presentation. This is very informative, it'll be very educational for everyone in this room about the state of Black mental health, exactly what is her assessment of African American mental health right now. So I'm going to hand the microphone over to her. She'll make that brief presentation, and then our keynote and adjunct panelists will react.
Good afternoon, everybody. And notice he keeps saying brief. That's to give me the word. Because those of you who know me know I am anything but brief. So when we talk about, I'll just put some data up there. You probably can't see it. If you do not want to call me, do not put that down. If you do, I do have some cards. So when we talk about the issues of mental health related to African American people, and I want to thank, first of all, before I go any further, I want to thank the organizers for putting this panel together. This is a critical piece because there's no aspect of health that isn't related to behavioral health. And so no matter what kind of panel or session you went into, everything has a behavioral health component. Now, when we talk about some of the stats, and I was told to give stats, but you know, I would have been one of those recalcitrant slaves because I don't ever do what I'm supposed to do. So I'm going to do a little bit, but then I'm going to go further, and then you can do the, the guy at the Apollo, pull me off. You saying, yeah. Yeah, so when we talk about mental health statistics, you know, population in the United States is about 13.2%, give or take a few, of people. About 16% of those have mental disorders, and we're looking at about 7 million people. And of those people, less than half get the mental health services that they need, and if they're of Caribbean descent, less than a quarter. So we really have some serious problems as it relates to our mental conditions. Now, when we talk about the factors, I'm just going to put them up there. Everybody knows what they are, but we can't exclude racism, whether we want to or not. It's there. It rears its ugly head in many ways. We cannot exclude poverty because we know the data supports that people who live in impoverished conditions, children who have bad nutrition, are twice as likely to have mental health conditions and other health conditions. We know that religious beliefs in some systems do not permit people to go to seek help. Thank God that we have now very enlightened churches and very enlightened faith-based organizations, but there was a time. And I can remember when I was asked about whether or not we should send somebody to a mental health counselor or to a faith-based organization, I remember saying that we need both. It's not an either or, it's an and. And then we have violence. We're subjected to violence beginning with our transfer on the Middle Passage to the present day. Every day our lives are constantly being traumatized with violence, whether it's police violence, whether it's family violence, whether it's whatever. And then we have this issue that Dr. Stewart alluded to, cultural competency, or the lack thereof. So when we talk about mental health issues, the first thing we got to look at is diagnosis. Our people are very often misdiagnosed. Sometimes people are suffering from depression and they get misdiagnosed as schizophrenia. That's been going on since time immemorial. Because when we sometimes get depressed, we get what you call psychotic, or we get paranoid. Well, I'm paranoid and I'm not depressed. Just living in America, it sometimes makes you paranoid. Then we have both implicit conscious and unconscious bias. Many people are not conscious of the fact that they are being biased in terms of how they treat or how they refer people for care and how they make those diagnoses. Then we have within our communities the overutilization of emergency departments, which raise the cost of health care. We'll come back into that in a minute. We have greater use of inpatient versus outpatient. We're more likely to refer somebody to an inpatient service if they're Black and psychotic than we will to see about them being treated in the community, which is anti-African in many ways. Now the jails have become the new mental health providers. There's the highest incidence of people in prison oftentimes have non-violent mental health disorders. And so we have to look at what that means in terms of our care. There is mistrust in the healthcare system going all the way back to the Tuskegee experiments and other issues. Dr. Nell Prim and others have written about this. So our people are not going to come in for care because they don't trust the care and they don't trust the system. And that's in a greater population. And even when they do come in, they're reluctant to do and follow up. Then there's a system-wide failure to recognize the impact that was alluded to of social determinants. If we do not deal with the social determinants of mental health, the cost is going to go up, the chronicity is going to be impeded, the lack of support and finances is going to occur because we've not looked at all the ways that there's intersectionality between what you see expressed in a mental disorder and what the reality of is in the people's lives that we have to deal with. And finally, there's inadequate cultural competency. Many people, I say, for example, and I'm gonna get through this quickly, you know, a patient will come in and say after a relative has died that they had a visitation. Somebody from another culture will call that a psychosis. But we know in ourselves that all of us who've had close relatives die often say we had a visitation. That is not a psychosis. So they get put in a system of being psychotic, put on medication, and they're not psychotic. Are y'all with me? And then, of course, we have this whole issue of medical insurance problems. You know, there's some states that are now decided that in order to receive medical assistance, which a lot of our people are on, they have to work. But what about the issues where people can't work? I was just looking at statistics. I was originally from Little Rock, Arkansas, before I moved here to the great DC, Maryland, the DMV. And I just looked at yesterday's statistics. 4,000 people were removed from medical assistance, and another 6,500 will be removed by the end of this month because they either didn't get the memo that they were supposed to come in and work, or they can't work, and nobody ever paid that any attention. So we're now dealing with some political issues that need to be addressed related to health care. All right, now, I know if you were there yesterday, you heard about ACEs. This is critical as it relates to our impact of our medical illnesses. We've got the abuse, we've got neglect, and we've got the household dysfunction, of which a large number of our people are involved in. And this is the adverse childhood experiences that lay the foundation, oftentimes devoid of biological stuff that you were talking about, but that look biological because they've been in family systems over generations, and so you misdiagnose them as being biological when they're cultural, okay? And then we have to look at what those things do and the adverse childhood experiences. They change behavior, I'm not gonna read them all, and the physical and mental abuse. I just did a lecture at the National Medical Association on the impact of sexual abuse in our families and how that relates to levels of obesity. And what we found and discovered is that children who have been sexually abused, if they were penetrated during that sexual abuse, they're more likely to have increased BMIs, which are associated with type 2 diabetes. There's an interrelation. You cannot separate the mind from the body. And so one of the things we have to look at is begin to tease out those issues that affect mental health that are already impacting your physical health. And the issues of trauma come into play with that. And so when we look at the brain, and I'm just showing you the pathways that occur, that when we see these traumatic effects and we get increases in the stress hormones and increases in the catecholamines, what we see then is a decrease in the brain-derived neurotropic factor, BDNF, and what does that do? That increases depression, that increases anxiety, while it's increasing catecholamines and increasing stress hormones that lead to diabetes, that lead to heart disease, that lead to all these things. Are you with me now? Okay. And so what we see in our population groups is with the traumatic effects. And what we know is we see PTSD. And what we don't deal with in general medicine is that we don't ask in the PCP, in the primary health care clinic, were you ever traumatized? We're just looking at you cross-sectionally, how you look now, not longitudinally what you brought into the dynamic. And so that affects us, and it causes an interaction between substance use disorders and affective disorders. We can talk about all that later. And so what you see in this slide here is that it's intergenerational. So once you get that pattern laid within the dynamics of the family, it gets passed on. We now know through the data that men who have been stressed and traumatized, there's a change in their RNA. And when their RNA changes, that affects also the fetus. Are you with me now? All right, I'm doing this fast. We got to deal with pollution, the issues around air, the issues around lead poisoning that have effect upon the neurological development and ultimately the behavioral development of our children. We have to look at the kind of foods we eat. Many of us live in neighborhoods that have food deserts. number one, and that is having an impact on mental illness. If a child is not properly getting nutrition, they don't learn. If they don't learn, they have neurological defects, but also there is a lifeline that leads them to being dysfunctional in school, that leads to them being turning into alcohol and drug abuse, that then takes you into the prison system. Are you with me now? So it's all there together, and I'm going fast because I got to. And so what we do is we're going to just give it to the Lord. Well, I come from an environment where God helps those who what? Help themselves. I'm almost done. And so you don't have to come and snatch me. Okay, so part of addressing our mental health challenges is that we have to increase our workforce of people who are culturally competent and understand the subtleties of the nature of what it means in African American society. We have to also eliminate the barriers. This whole thing around requiring people to work, I'm not saying, that's assuming that black folk like to get over, that they won't work, and that's not true. These are policy issues that need to be addressed. We have to reduce the number of people in jail. That means we need to have more mental health courts, more drug courts. We have to make sure that these people are referred to treatment rather than jail, and that money gets appropriated for them to be treated and also to have the kinds of backup services that support them. And that means increasing the funding for social determinants, for housing, for food, for all these other issues. And just now the data shows that some hospitals are now going into the housing business. They're going into the housing business because they recognize that the cost of care goes up when you're not dealing with the social determinants. Okay? And then we have to deal with public education. And that is the issue of our schools. We have to begin what I call primary public prevention of mental health prevention. The schools, the faith-based organizations have to be included in the dynamic, and the failure to do that means that we do not reach a large segment of the African American population, right? And then enhanced education and accountability of our elected officials. Mercy. Let me, at the Congressional Black Caucus, say that we are tired of psychopaths in suits determining the level at which we get care. I'm done with that. I'm moving on. That's a whole nother discussion. There must be increased advocacy from the African American community. You sit back, you don't ask for nothing, and you get what you ask for, nothing. And so here's the reality. Claude Anderson made a very interesting statement. He said that there should be a third political party, not one that supports any party, but one that supports an agenda. And if you come with the agenda and you say to this party, this is what we want, and they don't give it to you, you go to the next one. I rest my case. Come on. And so what do we have to do? As a people under siege, as a people with chronic mental problems who are not being addressed, we've got to rewire our neural networks. And that means exposing you to things that cause the changes in your brain to make you feel more empowered. It's trauma that makes you paralyzed. It's trauma that keeps you doing nothing. And it's fear carried from generation to generation that makes you feel less than and empowered. The suicide rates in young men are twice as high as they were 10 years ago. The number of people seeking treatment is not as good. And so therefore, these things are critical in rewiring the neural networks. And so I'm reminded of what James Baldwin said. In the context of all of this, people, we've got to be kinder and gentler to each other. We have got to stop creating stress amongst ourselves because we don't love ourselves, and therefore we project this anger and this hostility to our kith and kin that look just like us. We're not going to begin to change the mental health status of Black America until we get kinder and gentler to ourselves. Are you with me? And so part of the issue is that's it, folks. And did I make my 10 minutes? Thank you very much.
All right, that was great, Dr. Patricia Newton. Thanks so much. Another round of applause for that presentation. Because when we have discussions like this, or when I attend discussions like this, either as an audience member or as a moderator, I like to walk away from it knowing that I learned something new And I learned a few new things today, so I really appreciate that. And I expect to learn more over the next more than an hour or so as we now open it up for our keynote and adjunct panelists. I just want to introduce them real quick. I'll start from my immediate left and then go down over to farther to the left for the keynote panel, and then I'm also going to introduce our adjunct panelists as well. I have Tanya Edelin, Tanya Edelin, excuse me. She's the Director of Community Health and Benefit Strategy and Operations with Kaiser Permanente. And if you all have these sheets that are on your chair so you can get a little bit more insight and information on each of the panelists. I'm not going to read from this sheet, the bios in the interest of time. So Tanya Edelin with Kaiser Permanente. Also to her immediate left is Perry Daniel, Dr. Perry Daniel. He's Deputy Regional Vice President of K-12. He's also chair of the National Black Caucus of State Legislators conference or conference education committee that will be taking place at the NBCSL summit or conference this December in New York City. And also I know it says here you're a Hurricane Katrina survivor. You're not. You're from Louisiana, but you've dealt with the trauma and also yourself, your family dealing with a lot of that flooding in Baton Rouge and other places too in Louisiana. So I do apologize for that that incorrect information there. But and then to his left we have Dr. Jan Desper-Peters. She's the executive director of the Black Mental Health Alliance. And to her left is the Honorable Angela Angel, speaking of elected officials, delegate, but in a good way this time, Delegate Angela Angel. She represents Maryland's 25th district in Prince George's County, where I reside as well. So I'm a proud Prince Georgian, as well as a proud Philadelphian. So I gotta put my boys in there, fly Eagles fly. So, any brother that tells you they're not watching football this season, even though we are standing with certain folks, but they lying to you. But anyway, Dr. Angela Angel, Dr. Alpha Stewart, as you know, President, American Psychiatrists Association. Also to her left is Dr. Theopia Jackson. I love your first name, by the way. I meant to tell you that. Dr. Theopia Jackson, President-elect of the Association of Black Psychologists Incorporated. And to her left, Dr. Patricia Newton, CEO, Medical Director, Black Psychiatrist of America. So I'll throw the first question to Dr. Peters. As far as I wanted to get your initial reaction to this presentation from Dr. Newton. And if you all could also, if I can also ask the panelists to keep your comments, keep your questions, or interface with one another, to try to keep it brief, because I know we have to pack in so much within this 2-hour time frame. We started about 15 minutes later, so, but if you could kind of keep your comments brief to like a minute, I'd really appreciate that. Yeah. So Dr. Peters, I want to get your initial reaction to Dr. Newton.
Well, first of all, Mr. Ellison has elevated me. It's Jan Desper-Peters. Okay. And I went to the great University of George Washington University, not an HBCU, but not Harvard, but still great school. These are my notes that I took from Dr. Stewart and Dr. Newton. And the Black Mental Health, may I just for a moment just say what the Black Mental Health Alliance is. So we're a nonprofit organization. We're located in Baltimore, Maryland. We've been around for over 30 years. To be more specific, 35 years. We were formed by a group of mental health professionals, and Dr. Newton probably was in that group at that time, somewhere in that group, where there was a need to provide education, consultation, and training around cultural competence and cultural sensitivity. So we had great people like the great Senator Shirley Nathan Pulliam, who's also a Maryland elected official, and Dr. Maxie Collier, who is no longer with us, as our founders. So some of my initial reactions to both presentations, Dr. Stewart's and Dr. Newton's, is that they're amen. If I can be as cultural as a Black Southern Baptist girl can be, I'm going to say amen. A couple of things. One, the Black Mental Health Alliance continues to provide forums, and we see ourselves as a trusted partner as it relates to providing the opportunity for people like Dr. Stewart and Dr. Newton and community-based persons, what we call strategic subject matter experts, to come to the community to share information just like this. Because we know that if you don't share the information, then people will never know what the issues are, and they won't be able to name them. Or even when they go to their primary care physician or their mental health clinician, they won't be able to have a great conversation and articulate to the doctor what's going on with them. And so we think that having the conversation, continuing to talk about it, is very important. We also think that it's important, especially as it relates to policy issues, to continue to resonate around the themes of responsibility, accountability, and transparency. And so I'm going to step back a little bit and speak a little bit about public school system, especially in the community that I'm working in, Baltimore, where you have a system that has a $1 billion budget, and our children still have issues around reading proficiency and math proficiency. We have to be able to continue to speak out and have conversations around why is that, and holding people accountable and responsible as it relates to that. And then also continuing to train the people who have the most time with our young people, and that is educators, around the issues of mental health and mental illness, especially as it relates to children.
All right, thank you, Jan. Ms. Peters, Executive Director Peters, there you go. You sure you don't want doctor? No? Okay, all right.
I want it, but I want to earn it.
Give you that honorary designation. So, speaking of which, real quick, I noticed there were some comments, Dr. Daniel, here's a doctor, about education. I noticed that Dr. Newton mentioned it in her presentation about the state of public education, how that correlates with the state of Black mental health. So talk to that a little bit about how we may need to, I don't know, somehow modify or revolutionize or somehow radically alter the public education system.
Good afternoon to everyone, first of all. I think the first thing is that we need to be honest about where we are. I think that we all know that we can all probably think back to when we were in school and realizing that there was a student in our class or in our grade that just wasn't all there or didn't respond the way most kids responded. And a lot of the information that we saw today spoke to that from the standpoint of possible trauma in the home. And the first thing that we have to do in the work of addressing mental health is, like I said, is acknowledge where we are. The second thing, though, is that as educators, we're going to have to go back and say, hey, maybe the traditional training that we receive needs to be altered. So when you think about colleges of education, we've got to look at what types of training we're giving those that are going into the field of education. Okay, so we can't just stop with teaching them the pedagogical things. We got to also go back and teach them about supporting and serving the whole child. So there has to be some information about dealing with students with mental illnesses. And the other thing is just being willing to, I think, Dr. Newton, you said it best, being kinder and gentler. We've got to be willing to be more, looking at education more as a service and being willing to provide that service, but be kinder and gentler to one another. The other thing I think that we have to also look at is the system, educational system and the constructs of schooling may have to be adjusted a little bit. The one-size-fits-all does not fit anymore. So we've got to look at a variety of ways in which students are being schooled. And I'm not talking about, hey, sometimes homeschooling is looked on as a bad thing. Charter schools are looked at as a bad thing. But we've got to find the right school for the students that we're serving. And it may not be the traditional way. It may be, like I said, it may be homeschooling, it may be virtual schooling. They may be doing school at home where they're not being triggered with those things that may cause their trauma. Or maybe it may be a parochial school, but we've got to find out what works for the students that we're serving. So looking at acknowledging that there are issues with mental illness in schools, undiagnosed, students not receiving services that they deserve, or boys being diagnosed or I'd say too much for our boys. But looking at where we are, acknowledging that we need to do something different, providing teachers with the training that they need to truly support the students that we're serving, and then looking at the right educational environments that are going to provide our students with the opportunities and the supports that are going to get them to the next level.
You know, and talking about looking at new systems, you know, a lot of folks are very worried, Tanya, about the state of the healthcare system. And I know you represent like a major healthcare institution. And so, you know, this is sort of paraphrasing one of the questions that we received from the audience about how we begin to address a lot of these gaps and discrepancies. How do we do that through organizations, through institutions, large institutions like Kaiser Permanente's, like yours? How do you better manage those community connections with those institutions so you can facilitate the road to recovery as far as mental health challenges?
Absolutely. So just greetings from Kaiser Permanente, and I'm just going to talk a little bit about who we are as an organization. So we are a mission-driven organization and one of the largest nonprofit healthcare providers and insurers in the country. And one of our corporate beliefs is that we believe in total health, and that is not only freedom of physical affliction, but also mind, body, and spirit. And with that being said, I'm reflecting on Dr. Newton's presentation about the system's failure of social determinants of health. And we get it. We understand that health is not what we do in our doctor's office. That only represents 10% of what produces good health. We understand that those social and environmental factors do have a contributory factor on someone's health. And as we think about the work that we do, not only do we deliver high quality, affordable care within our offices, but we also are working within communities to address those systems and those conditions that produce poor health. We're doing housing. We recently announced an investment of $200 million in affordable housing and to address homelessness. We believe in the integration of mental health within our workforce development programs. So we're integrating those assessments within our workforce and providing those enhancements. So these are elements of which we believe will allow us to make our communities one among the healthiest in the nation, and that is inclusive of mental health and wellness.
Thank you, Tanya. I want to ask about policy, and I want to go to the delegate here. We got a few more minutes before we open it up a little bit more to the adjunct panel. And this is a question from an audience member. We have policy and we have budget, but where is our system of health care now? There's a lack of translation between policy and what we are actually seeing. This is actually, it seems like this might be from on Twitter. Right, it's from Twitter, hashtag CBCF Health, and also hashtag Black Mental Health. Delegate, I wanted to ask you about that, making that connection between policy and reality.
You know, and listening to the two previous presentations, which I agree, it was an amen moment for me. One of our biggest disconnects, and even us all sitting in this room, that I always call to the carpet that I want you to know is you are sitting in the wrong place. If you want to talk about mental health, and if you want to talk about, because do you know where you need to be sitting? You need to be sitting in your state legislatures, because those are the folks that regulate that policy. And too often we come here to DC and to Congress, and our Congress people are working hard at what they do, but we don't even understand that's not their lane. They can't even help us. As a member of the state legislature, I regulate health policy. We talk about parity in Maryland. We passed a parity law. I myself, I write more bills because I'm a single mother of 5. 2 of my children have mental health issues. Pediatric mental health is one of the things that I fight for. And I wrote a bill requiring that our Department of Mental Health, as well as our schools, the Department of Education, create a guideline so that we can implement mental and behavioral health in our school system. We did that on the state level. That's the only way you can do it. So if you really want to start talking about how we get the policy changed and even where the money comes from, you need to go to the states. And that's something that everyone, we always need to know about where actual power lies to make a difference. And once you get there, you find your advocates. You find, you know, in Maryland, the things that happen in pediatric mental health, they come to me because they know that's something I'm passionate about. And when I wrote my bill, it was just me. Like, it literally was an idea in my head after going to different conferences. And folks were like, I don't know if we're going to support that. And for the first year, we couldn't get it out. That next year, I worked day and night until they couldn't figure out how to tell me no. You know, when a Black woman is determined. And we got that passed. And the next step, to be honest, is going to be implementation and requiring our schools to give our babies the mental health that they need, because that's the only way they are going to learn, and we as a people will rise up and succeed. But it starts in the states, and that's how we begin.
No, thank you so much, Delegate. Dr. Theopia Jackson, this is a question from an audience member here. It's Cassandra, Dr. Scales over there in the audience. She's an OBGYN. She sees a lot of postpartum depression. And she finds that her white patients are more open to mental health support than her African-American patients. And even though the African-American patients have access for behavioral support or access and care, can get care for behavioral support. So what approaches can she take to get them to use these services, which she knows is not the case with many patients? And are there online resources that she should consider as well?
Hello, everyone. This is working.
Sure.
Blessings and greetings from Dr. Huberta Jackson Lohman, who is the current president for the Association of Black Psychologists. Well, we just celebrated our 50th anniversary, and to be very clear, what that really means is that we boldly walked away from the American Psychological Association, who is our corporate manager around issues of mental health. And the primary critique being is that they were struggling to understand and appreciate the impact of culture, and more specifically, how we were training psychologists were actually playing an active role in the oppression of people of color, particularly Black folks. So that's important as I begin to kind of come back to your question, because what I would submit to you is a both-and approach. I appreciate all the comments that have been said today. I feel full and special sitting next to these powerhouses, but I want to stretch the conversation to go beyond what's been said here. The realities are, what we call mental health in Western America was not meant for us. So it's the first problem is, how do we keep trying to put people into a box that was not fully appreciated for them? Every one of our institutions, the power that is sitting here across the board, we are all born from a system that continues to and has historically played a role in the oppression of our folks, either knowingly or unknowingly, because cultural blindness has been as much as detrimental to us as someone who's been very intentional about their oppression and bias towards us. So I might say I appreciate my sisters who are reluctant to, or hesitant I should say, to jump into the behavioral mental health services being brought to them, because it hasn't been critiqued to know that's really for them. Our current DSM, as Sister Stewart has mentioned, I want to be clear, it's a tool, but like any other tool, it's a dangerous one when used in a dangerous way. And it's been used in a dangerous way for us unequivocally, because within the DSM, we will forever be pathologized. We will forever need a diagnosis. It wasn't meant for us to step into our health and wellness. So what I would propose then, as I sit with my powerhouse here, how do we collectively come together to use our power, our legislation, to think outside of the box? We must continue to struggle within and outside of. How can we create health and healing practices that were meant for us, that are culturally affirming? How do we hold mental health programs and agency critical to, are they demonstrating cultural affirming in their work? Just because something has evidence base doesn't mean its practice is culturally relevant for us.
Right.
So we have to use the power to move this conversation forward. And I'll close by saying we are in a very unique time, because not only do we have the leadership here from my sister after 171, we also have the incoming president-elect for the American Psychological Association, being Dr. Rosie Phillips Davis, who's also an African-American woman. But more importantly, because this is important too, these are woke folks. Because the other challenge you'll pay attention to is we are all exposed to systems of oppression that we work from. We have to deal with our own internalized oppression. So many times we have folks who look like us who do more damage because they don't realize that they are doing someone else's work. I'm choosing that word. I'm gonna take a deep breath on that one. Okay, can't let that one out. So just in closing, I would say we have to hold ourselves accountable, each other and our people accountable, to come up with more culturally affirming, relevant healing practices for who we are, and moving away from this victim stance only, or problem stance of trauma. Oh, I'm sorry, I'm not closing out. I'm not following directions either. I want to add one statement about trauma.
Give you 30 more seconds.
I want to appreciate all the language around trauma, but let's be very clear. Before we name that, We know, we come from those of us who were born directly from those who were kidnapped and brought here. Excuse me, was that not trauma? Was that not resilience? So why are we on the bottom of every good list and the top of every wrong? I say because you're asking the wrong question. If any folks, you need to understand the lifeline and the power, understand how they survive and how we sit here. And this is also an international conversation. We talk about the global manifestation of Black inferiority and white supremacy. It just manifests itself differently, but we have to change the questions, come up with better tools, affirm ourselves, work together, and hold this power accountable.
All right. Thank you, Dr. Jackson. So we're going to transition this discussion. We're going to open it up to our adjunct panelists real quick. We also just want to, just a little bit of station ID, as they call it. This is identifying and implementing effective mental health strategies in the Black community. And we are pleased to present this to you as a result of a partnership between the Congressional Black Caucus Foundation and the Greater Washington Urban League. Our media partner is WURD Radio in Philadelphia. It's the only Black-owned talk radio station in the entire Commonwealth of Pennsylvania, and also other partners. We'd like to also thank other partners as well, such as the Black Mental Health Alliance, Kaiser Permanente, Black Psychiatrists of America. We also have the American Psychiatrists Association, APA is here. Trayron Center is also here. We're going to introduce Ryan Nickens in a quick second, Association of Black Psychologists, and also K-12 Incorporated as well. I might not have to do much moderating because I'm getting some wonderful questions and we're going to blend that into the discussion, but I want the adjunct panel, I'm going to introduce them now in a second to jump into the conversation. We have Kimberly Corbin again, Chief Financial Administrative Officer for Greater Washington Urban League. Ryan Nickens is founder and executive director of the Trayron Center, which is based here in DC, focused on a lot of the challenges that are happening east of the Anacostia River there in Ward 7 and 8. Lisa Daughtry is the principal and founder of Be My Keeper, and she's the co-founder of the Talk to Us blog as well. And I really appreciate you being here too, Lisa, because I know your son at 18 had took his own life, so I really am moved by the fact that you're actually here to share that with us today. Faith Bino is founder of Syncretic Wellness and the coordinator of wellness yoga programs at Alpha Street Baptist Church in Alexandria, Virginia. So we're going to open it up now. Kim, if you can, who had some response or reaction to this initial discussion? Ryan?
I want everybody here to meet this young lady. The trauma that she's experienced is tremendous. Losing two siblings and a parent?
No.
Uncle. Yeah. 2 siblings and a parent to gun violence. She went off, got educated, but she went back to the very same neighborhood where she lost her family. And she now has a nonprofit where she is working with youth who are experiencing violence in the very neighborhood where she lost hers.
See, I'm a crybaby, y'all. So I've learned my tears are healing, and I'm unashamed of them. Yes. So we work with youth and adults. The one thing I tell people that when I experienced trauma, I was glad that my family believed in Jesus and a good therapist, and they got me help. Because I was the suicide teen who considered suicide and tried it several times, and my family did keep it hush-hush. While I went to therapy, it was hush-hush, it was secret. When I began to talk about it, it was like, you can't tell our business because you're ours, and that's our business, and it's almost like we failed as parents, as a family, to protect you. And it was like, no, it wasn't your failure because you sent me to therapy. It was just an emotional response to the trauma that we experienced as a family. And to this day, I am the only one in my family who has been to therapy for what we have experienced as a collective. And so my organization does peer support. And we embed ourselves into communities that historically and for decades have experienced gun violence. And I tell people, if you trust me, and you trust that going to see a therapist works, and you can see a healed person on the other side of you, trust me when I tell you, go see a therapist. You are not crazy, you've just experienced trauma, and go see a therapist. It helps, it works. And because some of these young people trust and they can see healing on the other side when they look at me, they go. And I appreciate you, Dr. Newton, talking about our kids and the anxiety of our kids living in gun-ridden communities. We run an after-school program where we incorporate art therapy and the arts to help them to facilitate what they've experienced. And just last week, one of our 6-year-olds who was a part of our program was shot. And I went in on Friday to help facilitate the conversation with the community and with our kids. And they was like, oh, you know, they're primary school kids. They're like, oh yeah, she got shot. And I'm like, so how are you all feeling about that? It's like, oh, she got shot.
Yep.
It's sad.
Yep. Very matter of fact.
Can we get on the computer now, Ms. Ryan? Because you know the program don't start till Monday, so we can get on the computer. And I'm like, what do you do with that? And so I will talk to each one of you beautiful, experienced people to connect, because the psychiatrist, the psychologist that I am connected to are white. And they admit that they don't understand. And the representation is needed in our communities, because if I open the door and our people and the people I'm connected to trust me to seek help, I want to know that the person they're seeking help from will help them and not hurt them.
Yes.
Yeah, thank you, Ryan. Appreciate that. I do want to get some perspective from you, Faith Bino, about me. Thank you. From you about the faith community or the role of the faith community, because that's a big question. And I heard that in some of the comments from the keynote panelists and also from Dr. Newton's presentation. What is the role of the Black church? What should the role of the Black church be? What does that look like, too? How would we illustrate sort of a mental health response system within the Black church? Because so many people, I think there's an impression that they can get that therapy, they can get that sort of spirit, that sort of emotional nutrition, if you will, by just going to church every Sunday. But I know it's not that simple, but I'd like you to talk about that a little bit, and if you had a question for one of the panelists as well.
You just hit me with like 5 questions in one. I'm going to attempt to respond. So my name is Faith Bino. I am a wellness chaplain. I work in, and I do that in spaces that are formal, like hospital settings, and in the New York Presbyterian system. I do that within community, and I do that in partnership with a medical doctor, Dr. Tony Lewis of Liberation Health Strategies, and we work with rapid response teams. We work with communities and residents to provide healing circles, and I utilize my skills and talents as a wellness chaplain to that end, as well as the larger systemic issues. And again, I want to continue to place that it is through this lens, and I think the lens is critical. And so this lens is the intersection of integrative wellness and spiritual formation. Because what we heard on the panel is that everybody has their own spiritual grounding.
Yes.
Now, my container is the Baptist church. It is the Christian church. It's also influenced by the Yoruba practice, as well as by Buddhism. And I wanted just so that we're clear, we're talking about church, but we also need to be talking about mosques and temples. And for those who are not churched, unchurched, de-churched, or have no religious affiliation, and we know increasingly in the Black community that there are larger numbers of people who don't affiliate with a religious institution, but they have spiritual practice.
Yes.
And they have spiritual practice in which they're pulling from tradition and they're creating their own. And in some ways, that's okay and that's normal. That's actually the definition of syncretism. hence my business name of Syncretic Wellness. But when we have the thing that is missed is the opportunity for community and how communities lift each other up. So, so in answering, hopefully I'm moving through some of your questions, and part of this then becomes, with the strategic placement of leadership, is highlighting models, innovative models, and they're out there, of community and faith, religious and faith-based institutions, right? So I'll lift up 3. 1, First Corinthians Baptist Church in New York has the Hope Center. It is literally a center that the pastor, Pastor Warren, said, I'm creating a center that can help and support not just our members, but the community within Harlem in which they reside, to support them with their mental health challenges, needs, and supports. Coming from Alpha Street Baptist Church, and I am no longer there, so I just want to make that correction that there's somebody else there that's doing a lot of this wellness work. But the space of the innovation of Alpha Street Baptist Church, when I walked in, and this was, when it was a lot smaller, but there was the same energy still remains. The innovation, when I said, I am a yoga teacher, I do integrative wellness, I bring these modalities, and they gave me a budget line item. Like, I presented, budget line item, and began to then integrate, gave me space to integrate these practices, right? But specifically, they have a ministry called Agape, which is, and because it's a 7,000 member church, there's gonna be a few counselors and medical professionals that deal with mental health issues. And so this Agape ministry is there and provides a resource. So when we're talking about what is in our community that is culturally relevant, that is, has knowledge, may have data that doesn't look like traditional data. And I want to raise one other example, and this one I think attends to systems.
You've about 30 more seconds.
I got it. The Center for Health Equity in New York City, which are led by Black physicians, are also partnering with religious institutions, with healers like myself and Dr. Tony Lewis, so that we begin to continue to do the rapid response work with caregivers and with the residents that they serve. Elevate those kinds of innovations so that you force the partnerships.
All right, thank you, Faith, appreciate that. So I'm gonna start opening it up to questions from the audience, and this question is gonna open up an introduction to Lisa Daughtry, principal and founder of Be My Keeper and co-founder of the Talk to Us blog. And this question is from an audience member out here, and they're asking about how we could provide faster service for African Americans that are struggling with mental health issues, particularly as it relates to suicide, because I know we've heard a lot about suicide, and I think that's probably, I noticed the reaction of many people in the audience when some of the earlier presentations and discussion from Dr. Stewart and Dr. Newton, suicide is a lot more prevalent in the African American community than we know. And so with your experience, and are those services, are they diverse and culturally competent enough? I know that that's something you and I had talked offline before this event. That's something that was a big concern of yours.
Okay, so stand up for a hot second, I'm sorry. I used to be a board of directors for a national organization, and I left after 2 years because of the fact that when looking at the brochures and everything, it only identified not people of color.
Oh, can't hear you. Just
okay. It didn't identify people of color. So, and as far as in our community, we were not accepting the fact that we have to deal with the stigma. And I would say this, as far as with my son, I educated him as far as dealing with racism, police brutality, black on black crime. But when it came to depression, because of how the community is, he didn't want to talk about it. He didn't want to address as far as going to a therapist. So I would say as far as the resources, I would say, I see now that we're developing more workshops, and especially like this, where we have the panel discussions. But as far as resources, we still need it as far as with the community. We're not, I know we do workshops and meetups, but it's like we still ignore it. And I think Dr. Stewart said it. We only talk about it for 5 minutes when something happens to one of people of color. And I think we need to address it at home first. It's just not going to start with the community, but address it in your home. Talk it with your children. Talk with your family members. And I always ask a person, "Are you okay?" And I'm not asking you, "Are you okay?" I'm asking you, what's going on, because I can tell a difference with you. But as far as resources, I think we still need guidance with that. We still need to have a little bit more exposure.
Mm-hmm. All right, thank you. Appreciate that, Lisa. Oh, go ahead, Kimberly.
Yeah, so I just wanted to raise a question to all of you guys. We talk about resources, we talk about culturally competent resources, right? This is why we're having this panel, why all of you guys there. Who can pay for it? Mm-hmm. Okay, so let me just say this. I love my sister here. I'm a Kaiser person, and I talk to her every day, and I give her advice on what we need to see from the Kaiser system, right? And she's able to respond. I have a wonderful boss, Mr. Lambert. Raise your hand. That's the president and CEO of the Greater Washington Urban League. Everybody give him a hand. Who provides wonderful health care. And we provide Kaiser, and we provide, sorry to say this, but, Blue Cross Blue Shield. So if I have Blue Cross Blue Shield, I got Kaiser, I can go. I can get help. Without health insurance, who can get help? And so in this community of churches, right? If we don't have insurance, where else are we to go? We got to go to but we also need policy makers to make space in those safety nets for this too. And you raised your hand because I know you itching to tell me, where do I go if I don't have insurance?
First, I want to say we need to expand what we consider mental health and wellness. First and foremost, I like what our sister said here. For us, I would see it as more of a spiritual wholeness, right? That's the first shift. Secondly, not everything is therapeutic. Not every therapy is therapeutic, and not everything that's therapeutic is therapy, right? Because what our sisters have exemplified here is we can create health and wholeness and wellness among us as a community, being a village. Not everyone needs to see a licensed mental health practitioner. Yes, I am one, I just said that. And more specifically, as licensed mental health practitioners, we have to learn to practice not only within the settings that we're in, but within the communities we're in. Like I love when you talked again, when they're part of a faith-based organization, how do you lend yourself to that as well too? So examples of this would also be the work that's being done around the Emotional Emancipation Circles, which is a vision of the Community Healing Network, who came to the Association of Black Psychologists and said, how can we have a curriculum, if you will, for lack of a better word, that will allow our communities to do their own work around self-healing? And so we created this, and it's not predicated upon a professional being there. We've turned these over to the community, and they're operating all over the world right now, right? If anything, it may help our communities be better consumers of the mental health services, knowing when and how to come and what to ask for, and also it may create more space for diverse funding sources and also more around rapid response. So I'll just close by saying, again, this is what I meant earlier about trying to be more innovative as we think out of the box here. How do we create healthier communities? Because within that context, we will have more kitchen table conversations about the real issues that we're dealing with, and sharing each other's stories and learning from each other's stories, and then knowing which healthcare provider is the right one to go and see.
So I want to respond
Go
to
ahead,
that,
Tanya.
because you're right, we have to be more innovative, and one of the things I'm most proud of to date with Kaiser Permanente is the partnership we have with Jan at the Black Mental Health Alliance. And this is where we're bringing mental mental health services into the beauty salons and barbershops in West Baltimore. And I'm going to let Jan speak a little bit more about that partnership. But when we also talked about where we need to place those services and resources in our institutions, not only within our healthcare settings, we at Kaiser Permanente are making sure that we're doing those screenings in the primary care settings. We're making sure that we're recruiting the physicians and the providers to support our diverse population of membership. But also when we think about school systems, a story that I want to tell is that we were bringing sort of a healthy eating type of active living program into a West Baltimore school system. It was called Real School Gardens. We were going to do curriculum builds around, healthy eating and bringing math and reading into that setting. But after talking with the principals and the teachers, they said, that's not what we need. Mm-hmm. We have students who have trauma. Mm-hmm. And so that made us think and take a step back and say, let's bring what is needed to the school system. And we created a partnership with Roberta's House. And Roberta's House is a nonprofit organization that provides grief counseling and what is needed to address childhood trauma. And so when we think about the needs of our community, we're making sure that we're bringing the right resources and in the right settings. Another example I shared earlier was about our workforce development program, and I'm going to tell a quick story because especially it relates to suicide. So this particular 22-year-old young lady, she is a first-time parent as well as a single mother, and she lives in one of the unhealthiest zip codes in the state of Maryland, in West Baltimore. This woman has an effervescent personality, and she is one of our brightest stars in our certified nursing assistant program. What we learned through funding this workforce program, we realized that doing that was just not enough. We needed to provide a behavioral health assessment and a referral process. And through that process, we identified, and to our dismay, this young lady had the beginnings of suicide ideation. We were floored by that assessment. But what we realized is that what would have happened if that assessment wasn't in place, right? So as a healthcare provider, as well as a philanthropic funder, we realized that we play a role in creating comprehensive solutions to mental health. And that's exactly what we are doing at Kaiser Permanente. We are continuing to look through an equity lens and how we address the mental health needs of our communities. And so those are just 3 examples of how we're trying to provide resources in the right settings to the right folks.
Thank you, Tanya, for saying that too, because one of the outcomes that we want from this conversation is to at least sketch out something of a mental health response ecosystem for especially the Black community, as traumatized as it is, and obviously the panelists have done a fantastic job in sharing that and illustrating for us how really urgent the situation is. And I'd like to encourage the panelists as well as a little bit of the talk show radio host in me. Feel free to jump in. We're going to continue going on. We have on the clock, we have about 15 more minutes left of this conversation. I'm wondering, I'm going to look at my foundation colleague over there. Should we take another 5-10 minutes even after that 15? Can we do that after the 3 o'clock?
I don't think we have another session in this room, so we can do that.
Okay. So feel free. I'm going to take the liberty of taking another. I know, I see it too. Yeah, there's a lot. And I appreciate folks there are folks online on Twitter at #CBCFHealth and also #Black Mental Health. So there's a lot of discussion that's being generated in addition to our Facebook live stream of this event right now. So I want to encourage the panelists to feel free to jump in. So if something strikes you, if something is pushing you at the moment to say something or ask a question, please feel free to. And please, audience members, continue. I'm going to actually have all your questions asked as we continue this discussion. One question strikes me as really important, and it talks about that correlation between poverty or socioeconomic circumstances and the state of Black mental health. So, like, for example, east of the river, here in Washington, D.C., you have rising violence. We've been seeing that, a lot of rising structural community violence. I don't like to call it Black on Black violence. I don't think there's honestly, there's not really such a thing as black on black violence. It's just, it's everybody living in close proximity to one another, right? And it's internal structural violence. But there's a rise in structural violence, community violence, while the poverty rate in Ward 8 is about 38%. And that almost matches the number of adults in Ward 8, and it's a majority black ward, right? Who are diagnosed with some sort of mental illness or clinical depression. So this person in the audience asked, how do you instill hope in a community that's struck by generational poverty, deep, embedded generational poverty? How do you address that? And that generational poverty normalizes the depression that's felt. And so I want to throw that out there. Maybe Dr. Stewart, because I know you haven't spoken in a while since the fireside chat. Maybe I'll throw that out there to you first. Is that something that the APA has discussed internally, perhaps, that poverty element, because it's so huge, particularly as it relates to black and brown communities?
No, we talk a lot at the APA about, or we talk more today than before, about social determinants of health, and certainly poverty is right up there as a number one issue across the board, particularly for black and brown folk. But your question, actually, I may have sent you a subliminal message, I'm not sure, because your question did trigger something in me that brings to mind someone else that I frequently look to for guidance and inspiration, just in sort of the way he approaches it. And I don't know how many of you know the name Brian Stevenson, very well-known attorney, civil rights attorney, and he works a lot with individuals on death row and kids and mentally ill people and folks for whom the justice system is the default for what their real need is. Somehow they've managed to get the trajectory into there instead of where their real needs are. And Brian talks a lot about preserving hope, maintaining hope. And in that context, he begins to describe the way you do that as in a couple of ways, that we must remain proximate to it. We cannot run away from it. We cannot divorce ourselves from it. Someone like yourself who said, this was a tragic geographic location in my life, and it left me with lots and lots of reasons not to want to be here and not to want to do this work. But rather than move away from that, you made a conscious decision to actually move towards that and figure out how to navigate both your own individual and personal trauma, but to see the big picture of, if this is happening to me and I am feeling this way, that child over there who's witnessed this 10 or 12 times in their young life, or who had their mother die in their arms, or who's been bounced around from family member to family member because every reasonable adult in their life has been either taken away, killed, died, or is incarcerated. Mm-hmm. And that by remaining proximate to it, it both forces us to face it, but it also engages us in what to do about it. Mm-hmm. And I think the maintenance of hope, especially for children, and especially for children today, has got to be a number one job that each of us, whether we have children or not, commits to, that every child in the community is my child. Yes. Every child I work with in the juvenile justice system is my child. Yes. Every child in school who is driven to the behavioral disciplinary track, or the truancy track, or the you'll never amount to anything and why are we bothering to keep you in school, so why don't you just drop out track. That each of those children belongs to each of us. Yes. And there is something that we can do to engage with them in a way that offers them at least the possibility of hope.
It's like that community schools approach, right? Like the community school that LeBron James recently opened in Akron, Ohio. And going back to my hometown, Philadelphia, I know the mayor of Philly was here in DC recently talking about community schools and how they're starting to expand that web as well. So is that a, and Dr. Daniel, I want you to comment on that after Dr. Stewart. Is that a viable approach to integrate all of those various resources into a school?
Absolutely, because two things happen when you have that approach to, at least to education. Two things happen. Children begin to see that they are no longer being measured by standards that they even realize they don't measure up to, that leaves them hopeless and distraught about any future. And communities see that that traditional approach to educating that Dr. Daniels mentioned earlier doesn't work for everybody, that traditional model is not the only one that can lead to a successful outcome. And when you instill that kind of hope into a child or an adult in a community that has been left hopeless, you have a much better chance at them. It's like contagion, that they now can believe it, and they can pass it on, and before you know it, everybody's more hopeful and therefore doing things to maintain hope.
Thank you, Dr. Stewart. Appreciate that. Dr. Dan, you had that education component. And thank you to April McCraw, who she recently passed her clinical exam, by the way. She's a social worker, LCSW. She asked a question about generational poverty, and I appreciate that, April, too. We needed to address that. Go ahead, Dr. Daniel.
Wanted to say, first of all, in reference to April's question about that generational poverty, we got to make sure in schools that there are educators and I'm saying us, we have to have a belief that it can be better. So there's that belief gap in a lot of schools that the kids don't, or if they're coming from a situation where it's that generational poverty, there's that gap of belief. And if we don't believe that it can be better, it never will be better. So no matter if there's whatever program, whatever funding we get, if there's not a belief, if it doesn't start with a belief that we are going somewhere, we're going to be able to achieve this goal, it's not going to matter. When you talk about the communities in schools, as I said earlier, we've got to put in place things that are going to address the needs. Sister here said it about what they were doing at Kaiser, of just wanting to give but not giving what was needed. And I think as educators, it's almost like in a relationship. You can't love a person the way you want to love them. You got to love them the way they need it and the way they want to be loved. And so in the same thing, in this vein of communities and schools, each community school may be totally different because of the community that it is involved or that it's engaged in. You got to give those schools, like you said about gardening, doing something for health. If that's the need of that community, that's what you do. But if you also see there's a need for mental health services, you encase that into the daily life of those kids. You have the additional counselors in the schools. You have someone that's providing mental health services. And I've had an opportunity to work in a couple of schools where there was a mental health professional in the building. And that would do small groups with students, would provide grief counseling for those students. And that's what, as educators and policymakers as well, we've got to find a way to create those opportunities and build those partnerships so we can create those types of educational environments for our students.
And so, Charles,
go ahead.
Before you move, I just want to jump very quickly.
Real quick, Dr. Jackson, and then I'll have Delegate Adrian.
Okay, just expand on this. As we want to pay attention to our language, I think we want to move away from saying at-risk youth, because in our Western society, that means the problem is still in the child. But if we say at-risk, at potential youth in at-risk environments, it says that what's happening to them, what's going on around them, and therefore how can we impact change in that environment to support them. I also want to expand on this idea I love in terms of loving our children, but also love the families from which they came, because that too has been part of our ongoing internalized racism operationalizing, which is we're still going to say someone else's children, but your blackness is not my blackness, right? And so to move that multi-generational poverty and psychological woundedness, which is what I would call it, versus mental illness, it's like because their behaviors are normal reactions to abnormal situations.
Absolutely.
So these are psychological and spiritual woundedness that's happening. So if we shift how we think about it, it can help inform how we approach into it. So as we bring in the children love, ask ourselves, how can we also bring in their family?
Yes.
Because to only love the child in that moment and send him or her back into the same setting without giving, we haven't really added on a long-term basis. So I just want to continue to push us to open it up that critically and that clearly.
Thank you, Dr. Jackson. So Delegate Angel, and then Ms. Peters. after Delegate Angel. Go ahead.
I love it because I feel like it's like a WWE tag team moment. You just tag me in. Because I'm actually going to pick up right where she left off in the fact that I'm going to bring it back to where we are in policy. And I'm bring it back to the environment and the folks, even the folks that you were electing that influence those environments. Part of the issue is we're not changing their communities. If the same people that are in the same offices that in the community looks the exact same that it's been for all of these years, we have to begin looking at what the real issue is. One of the things I was amazed when I went down to Annapolis were that people that were there for years, and when I came in writing 20 bills, they were like, "You doing too much." And I was like, well, what? And literally, I've been told constantly in some of the chatters, well, she does so much. You know what? 4 years ago, 6 years ago, I was homeless. Okay, with 5 children because of a bad divorce and a violent marriage. I'm down there working because I know that my sisters are dying in the streets, and I'll be damned if I don't go down there and fight for them. But there are too many folks in positions that can make that change that are sitting on their laurels. And it's about time that we as a community begin saying we will have those seats and give them to somebody that's going to do the work. Because that's how we begin to change the community, the environments, that rebuilds the mothers, that rebuilds the sisters, and that rebuilds the children. And that's something that we have to begin doing.
Jan, you'd like to jump in?
Yeah, I would like to jump in. So Delegate, amen to you too. So I just want to go back a couple of questions. One, Kimberly asked with regard to the funding and where does the money come from, which will help me tie in the partnership we have with Kaiser Permanente. So the Great Health, Good Hair partnership that we're in with Kaiser Permanente kind of piggybacks on a health and wellness component that they created in Baltimore, specifically West Baltimore, and it includes primary care, screenings, but also help with employment opportunities and financial management. One of the things, and exercise and health and wellness. But one of the things they realized was that they were not addressing the mental health component, and that's when they asked the Black Mental Health Alliance to come in. So specifically what we do is we go into one of the beauty or barber shops that's partnering also, and we have a conversation, just almost similar to what we're doing here, except that then there's usually a presenter, but people get the opportunity to be intimate with the presenter and have question and answer around that. One of the ones that sticks out the most for me was when we had a mother who had gone through a journey with her son who had been incarcerated and was now a returning citizen, and she wrote a book about that. And there was a young mother there who had a son who was in the process of going through the court system and was probably going to be incarcerated. And the group of people that were there rallied around her. We were able to give her resources. We were able to love up on her in a way that I believe she needed at that particular time. So for the Black Mental Health Alliance to create these community spaces with the assistance of partners like Kaiser is important to the work that we do. The other piece that I wanted to talk about was in relationship to the budget and the EEC, because the Black Mental Health Alliance also is a partner with Community Healing Network and the Association of Black Psychologists, because we've been running EECs in Baltimore for about 3 years or maybe more. And people really don't want to fund EECs because they want to have us then produce outcome data for them. And the model for EEC is not a traditional model where you go in at Key 1 and you have a survey, and then you go for 7 weeks, and you can have a survey at the end of the 7th week, and then you can see outcome data. And because it's not clean like that, it's difficult for a funder, a foundation, the government, whomever, to then fund that program. And so what I'm asking you to do, and what people always ask me, well, Jan, what is it that we can do? Then we can fund our own programs. We can fund our own programs. We don't have to wait for someone else to do that. Okay, I'm finished because I think I'm getting ready to get this over.
No, that's all right, Jan. Just add Dr. Newton.
Can I just add one point?
Yes, ma'am.
I think it's critical for those of us who live in communities where businesses operate that we begin to charge them with the responsibility of allocation of funds toward the mental health issues. One, they're less likely to be robbed. 2, they're less likely to lose revenue. And 3, we will begin to also employ our young people and to create our own jobs so that we can begin to empower our own communities like we once did before integration, and begin to actually put aside X amount of dollars, which become tax deductions, for you to be able to fund the programs that we need to empower ourselves and to heal our people.
Go ahead. Faith, and also Faith, Ryan, Lisa, definitely jump in. Okay, we have 15 more minutes.
Can I just make one comment about
Sure,
language?
Dr. Stewart, go ahead, and then
And
we'll go
I
to Faith.
apologize, but Dr. Jackson reminded me of something that I usually say in these settings that I fail to say. Language, sticks and stones may break my bones, words will never harm me. That is a lie. That is a lie. And I have to say, there is the beginning of a national campaign to change our language. What you said about youth at risk fits neatly into that. I'm on a cause to stop using the word juvenile. It brings all kinds of images to mind that we need to stop. None of us get up in the morning and say, what's on my juvenile schedule today? And if we don't do that to our children, we shouldn't do it to others. So I just wanted to put that out.
Thank you. Thank you for saying that. Go ahead, Faith.
I want to quickly build off of what Dr. Newton said, as well as the framing for being an anchor institution, a responsible anchor institution, and what it means to have strategic partnerships. As hospitals begin to shift from volume to value-based healthcare, and they are realizing that they have to work within teams, you're now seeing not only that, and realizing, okay, we can't do all the work on our own, there's opportunity for strategic partnerships. The church is an anchor institution. It can't go nowhere. It often is, it is a revenue generator, and it provides jobs. And the same way that Dr. Newton is saying, go to these businesses, is to go to the church and demand those things because they're in their neighborhood, and then be willing to be innovative in how you do it because many of them are under-resourced.
Yeah, thank you, Faith. Also, there's another question. This is from Masapula, and I please accept my apologies if I'm mispronouncing this name. Masapula Sahole. I think I might have that pronounced correctly. I hope I do. But their question is, how can we challenge the linkage association between mental health, air quotes, and violent acts and crime, which I think is a very interesting question, because every time one of these mass shooting events happens, there's a quick reflex towards a conversation on mental health. So how do we address that? I'll just open that up to all the panelists. Anyone want to jump in on that question? Go ahead, Ryan.
I think the only time mental health comes up is when it's a white boy.
Yes.
It does not come up when it's a black boy from Southeast who probably grew up with a drug-addicted mother, no resources to help him. That doesn't come up. He's a juvenile offender. Or better yet, he's an adult. He can be 15 and he's a grown man, and he's about to get life in prison for the rest of his life because nobody checked in. So that doesn't happen for our people. We don't get the benefit of our trauma. We don't get the benefit of growing up in communities that have been saturated by gun violence and nobody checking in. The church isn't checking in because most churches are now commuter churches and urban environments, and because they don't live in that community and they only show up on Sunday morning, Tuesdays for choir rehearsal, and Wednesday nights for Bible study, it doesn't matter. But when I get in front of black church people, it's but what happens when you walk out on Wednesday night and, little Billy blop you upside your head and take your car? Are you going to care then? Are you going to care about where he is? Mass shootings don't happen for us, so let's take that off the table. Well, no, they do happen for us. We have a slow genocide that is happening in urban environments with black and brown kids. There is a slow, steady massacre. 107 kids have been killed in Washington, D.C. People over this year. This year, last time, it was 78. So we have a slow, steady massacre that's happening that we need to address, and we are re-traumatizing ourselves. I had a 5-year-old little boy whose father was killed 2 years ago, and he said, when I get big, I'm gonna kill the man who killed my father. because he's already made up his mind that he wants retribution. Somebody's going to pay for his pain. And that's what we have to do with that. And then the other part of representation. Me being back means that they see another healed person, that I can get through this. If she did it, what makes her that different from me? And so representation means everything. It doesn't mean that you've gone through gun violence at the level that my family and I have. It means that you are a Black person who has found a way to succeed in this world, and you show up back in our communities to help our kids see the resiliency in you and how they can make it as well.
Thank you,
and you
Ron.
give them the coping skills.
Thank you, Ron. I appreciate that. We're going to start wrapping up because I want to get some closing remarks from our partner, Anne-Marie Burton at the Congressional Black Caucus Foundation, and also Kimberly Corbin at the Greater Washington Urban League. But I had this last question struck out for me. And also for all of those who have audience members who've submitted questions, I'm happy that we had a process whereby you could write them on these cue cards because we're going to include these on the record. We're actually extending this conversation in the digital space because this is actually the first stage of a series of conversations, but also the start of us literally building that framework, that ecosystem that you've been hearing it, right? Pieces of it in this conversation that we're going to build, like I heard, different elements such as obviously healthcare institutions and, the need for insurance, the church, the public policy arena, also awareness, advocacy. We need those communications professionals, those messaging strategists out there, education systems, school systems. Also, I heard about nutrition earlier on. So we are literally using this conversation. This conversation was really not a panel discussion. This was a brainstorm session that you've all been involved in. So you actually, as audience members, you contributed to that. You weren't just folks sitting in a panel room during CBC week and asking questions. These are actually going to be used for us to expound on this conversation that took place today here. But this one I really liked, and it's a little bit somewhat on a personal level. But how do the panelists handle their own mental health issues? I want to throw that out there. And they're asking because they've had difficult sessions with clinicians who stopped this person to share their own experiences, their own issues with mental health or mental health wellness. And so I want to throw that out there. If any panelists are brave enough to talk about that.
I would love to start. And I appreciate the
Real
question.
quick, we'll go about 30 seconds each if you could.
I'm spewing. I appreciate the question. It's important to know that I, too, am, again, a survivor of multiple ways. I'm the oldest of 7, born to a single parent, survivor of sexual abuse, poverty, the whole bit. Knowing that story in a healthy way is already part of the empowerment that I am from the community in which I'm trying to work with. Also, I'm blessed because when I work with children who are living in complex trauma and in impoverished environments, I am just as transformed as they are in this healing space that I'm trying to create for them. And I'm very clear that my work is about a healing space, and it involves their family and their community, because I can't help the child if I don't help the family. So this is what sustains me in this work. And as long as the community continues to tell me I'm doing right by them, then I'll continue to be. If I get a different message, then I know it's time for me to check myself. And I also close by saying I also have my own healing circle. I know my people. I know from whence I came. Folks here will check me if I'm off the reservation, if you will.
Lisa, service as therapy. I like that.
With
Lisa.
me being a survivor of losing my son, I had to go to a therapist because I started having anxiety, and I have PTSD as well. I would say this: I know people do not like going to therapy, but if you're not comfortable with the person that you're going to, just go to another person. Just don't sit there and not be satisfied or not getting fulfilled from your sessions. That's all I want to say.
No, I appreciate that, Lisa. Anyone else want to jump in on that question? Go ahead, Dr. Daniel. Oh no, Dr. Jan. Jan, go ahead.
No problem. I was just going to say that it's also important to have a circle of friends. I'm going to call it a sister circle for me. Yes. Brothers would call it something else. But a sister circle.
Brotherhood.
Brotherhood, right. I'm a breast cancer survivor, and recently I had some surgery. And one of the things that was so amazing to me, I always knew I had this sister circle, but the way they rallied around me as it related to even creating a meal train for me and my family, and checking in with me to ensure that Jan is taking care of Jan, because I'm so busy always thinking about other people, like many Black women are, that I can tend to neglect Jan. And so having that sister circle, that inner circle, in addition to the professional therapist, I think is really, really important.
That's right. All right, Dr. Daniel.
And particularly as a young man, and it's not, I see a few brothers in the room, it's so important for us to consider ourselves lucky if we have friends and men that we can talk to and connect with, that we can be honest with, but that will also be honest with us.
That's right.
I think the one thing you said, just all of us need a pull-up pal. Somebody that can tell you, hey, you stepping over the line. And hey, you're crossing over into something that's not you. Regardless of what you're experiencing in life, being true to who you are. And when people see you stepping out of that, you need people that can tell you and say, hey, I think we need to have a different conversation. Or, hey, I think you need to go talk to somebody. That's what, I've experienced a little bit of challenges in life, but the one time I did, my friend say, man, are you going to talk to anybody about it? And I did. And it was probably the best thing for me to do at that point in my life, to go sit down and sit on somebody's couch. So.
All right.
I'd just like to say that everything that's been said is critical. Developing a strong spiritual base, not necessarily religious, but a strong spiritual base to understand you as an extension of the divine is a critical, important piece for your healing, because in the absence of that, you become just like everybody else. So that's the first thing. And I don't care what religious group you do, having that spiritual base is critical. Having the support system of like minds, folk you can call on when you know you're in trouble, not being in denial, and allowing yourself permission to be angry. Be angry but not destructive. Because don't say, I'm not supposed to feel this way. Feelings are important. It's what you do with them that are critical. And then periodically, I gotta leave America. I just gotta tell you that for me, I have to get off the plantation and periodically go somewhere else where I can get sun and shining and food and natural healing from my peeps. All right.
Thanks, Dr. Newton. So Tanya, I'm gonna give you literally 30 seconds, and then Faith, you'll get the last word, 30 seconds, because I just want to get quick comments from Ms. Burton and also Ms. Corbin. So go ahead, Tanya, go real quick.
Absolutely. So I'm going to say ditto, ditto, and ditto to everything that the panel has shared, but I'm also going to respond in a way that's sort of personal for me, and being the introvert that I am. Personal meditation and being still and really that reflection is very important. Sometimes the voices of others can sometimes not connect with you in a way that meditation can. So for me, restoration is meditation, as well as being around things that made, nature. And being in a space of greenery has been, I'll just say, my godsend as it relates to restoring my spirit, restoring my mind, as well as restoring my body.
That's right. All right. Thank you, Tanya. Real quick, Faith.
So real quick, yes to meditation, and know that in the beginning of the founding church, the Desert Mothers and Fathers in Alexandria, they were the ones that created the space for meditation that people then took out to other parts of the world. So it is ours. So find the one that works for you. The Black Yoga Teacher Alliance, if you like yoga or you trying to figure out yoga, but you don't want to have in spaces that you don't feel comfortable or you feel attacked, go and find a teacher that's there, as well as know that we have for millennia had our own tools and techniques that we have masked, that you may think this isn't, the auntie and uncle just kind of casually said it. Revisit those things that you know actually are a healing solve to you.
All right, thank you, Faith. And it's nothing like a run or a hike in the park. Delegate, go ahead.
I'll just close
30
it out.
seconds.
I agree with everything that everyone said, but I will also say no matter how broken you are, look at that moment that you're in and look forward to the hope and know that you've gone through it for a reason and that your power will come from it. I wouldn't be the advocate that I was if I hadn't gone through the struggle that I went through. So just know and hold on to that hope.
All right, thank you, Delegate. You get the last word. Dr. Stewart, I got to give Dr. Stewart the last word.
I know you weren't going to try to close it out by saying so.
Dr. Stewart, go ahead. We'll give you 30 seconds.
You were just teasing. Okay, all right.
Let me hide over here.
Everything that has been said works well, particularly something Dr. Daniel said about understanding, when someone says to you, this ain't you, you need to stop, understand and appreciate that person in your life. The other thing I will say is knowing where you draw the line. Your moral compass will save you so much stress and aggravation, because once you know what you will not do, no matter what, all of that stuff that people put in front of you to tempt you won't matter. It won't lead you down the path of self-destruction. It won't create anxiety and stress and turmoil in your life. Know your own moral compass.
Thank you, Dr. Stewart. You indeed get the last word. Dr. Alpha Stewart, President, American Psychiatrists Association. Dr. Patricia Newton, CEO and Medical Director, Black Psychiatrists of America. Jan Desper-Peters, Executive Director, Black Mental Health Alliance. Dr. Theopia Jackson, President-elect, Association of Black Psychologists, Incorporated. Perry Daniel, Deputy Regional Vice President, K-12. And also, if you're in New York, I think it's November 29th, 28th, check out the National Black Caucus of State Legislators. Do you know that there are 700 black state legislators in the United States? Powerful. 700 throughout the United States. And many of them are leaders in their legislatures. I had to end with that. Speaking of legislators, the Honorable Angela Angel, delegate representing the 25th Legislative District of the state of Maryland in Prince George's County, Tanya Edelin, Director, Community Health and Benefit Strategy and Operations at Kaiser Permanente. Also, Lisa Daughtry, Principal and founder of Be My Keeper and co-founder of Talk to Us blog. Faith Bino, founder of Syncretic Wellness. And Ryan Nickens, founder and Executive Director, Trayron Center. So real quick, we're going to get some closing remarks from Anne Marie Burton of the Congressional Black Caucus Foundation, and then afterwards, Kimberly Corbin. I'm Charles Ellison signing off, and I have to get ready to actually broadcast from this very room in the WURD at 4 o'clock, so you can all watch that a little bit later on.
Wow. Thank you all for staying. This was a bit of a tough, emotional conversation, can you say? But it was necessary. And Charles, fantastic job. Thank you. Excellent. Can we give him a round of applause? To all our panelists, this was the beginning. That was round one. You all had that was our brainstorm. So when we call on you for a more in-depth conversation, I hope you will be willing to continue this dialogue, because it is critical. There was so much we could have done and gotten into, because I really think we need to get into the root causes. We can't put Band-Aid solutions to things. We need to understand that if a child is having psychological issues, like she rightly said, taking care of that child at school, but sending them back to the same environment is a Band-Aid solution. That is not a long-term solution. Talking about mental health should be the way we talk about diabetes, blood pressure, and there should be no stigma to it. You know, the church should be talking about mental health. You know, sometimes we try to hide it under spirituality. You know, just pray it off. You know, it's just, yes, I'm a Christian, born-again Christian. But it has its place, and I will go and get help if I need help, because we live very stressful lives, very, very stressful lives. And we need to call it what it is if we're really going to move forward. So I am energized, I'm excited. Prior to coming to CBCF, I was the national director at NAMI. So I want you to know that I know these things, I get it to the bone. I am a mom of 2 boys, you know, I'm Black. And we all know that even the news is traumatic nowadays. It is. And so when we talk about self-preservation, I will tell you this, true story. I started noticing that I was having just weird behavior. Like I was stressed. I remember going to the masseuse and she asked me what was going on. That's how stiff my body was. And I just said nothing. And she goes, no, this is not normal. You are a brick, she said. And she couldn't even start kneading on me. And so I remember leaving there. It was painful because obviously I didn't relax because it was so, it's kind of like I got more trauma from that. But I went back and I called my physician. I said, we need to talk. I went to see the masseuse and this is what she said. And I didn't realize how much trauma I'm internalizing. So she gave me a referral and I did go. And we just started talking. And it turns out that my habits were part of my problem. Obviously, my job was stressful enough. That was one. But guess what? We started talking about what I do in the evening. I soak in MSNBC, right? And so before I go to sleep, I've been assaulted by all that news. And then they put it on the rerun, right? And so turn it off. Turn it off. Don't watch the replays. When the child, he died, right? That's the rerun of watching us getting killed and shot over. And they play it and they play it. That is mental trauma happening to us every second. So I started changing really simple habits. I listen to classical music on the way in. I don't watch TV when I get home. Guess what? I just listen to NPR because images have an effect on you as well. So if I just listen to NPR on the radio as I'm making dinner and fighting with everybody for homework, I'm in a better space. I'm sharing that because it's as simple as changing some habits because we don't know how much we're internalizing the forces that are hitting us on a minute-by-minute basis. It's in your music. So just be mindful. I really liked the mindfulness, One of the things I actually had the boys' school, I have 2 sons. I started talking, they go to a Catholic school, so I couldn't talk about meditation or yoga because of religion. And so I said, I took this breathing technique and it has changed everything. And I'm just going to have us close out with let's try to breathe. Just stop everything you're doing and let me tell you how crazy amazing this is. Do you know that when you're anxious, the first thing you can control is your breath? That when you're upset, you realize how much you're having short breaths, so there's no oxygen, there's no clarity, you're constricting everything. So, they brought in, I'm almost done, I promise. So they brought in, we now have like a clinician and everything at the school, but I went and said, can we just try breathing? And they said, yoga? I said, no, because I knew they were going to shut that down as soon as I said that. I said, visual breathing, where the children can reflect on something. And once you've done morning announcements, try breathing. The effects have been amazing. So why don't we just try breathing? I'm just going to ask you to just, I know you're holding the mic, so you can still try breathing. But why don't we just take a few moments and just follow my guidance? Are we ready? Yes. All right, I'm going to have you breathe in slowly. Breathe in, take a deep breath. Don't release it until I tell you. Exhale. Deep breath in. Exhale. Relax your shoulders. Deep breath in. Exhale. Now I'm going to ask you to take a deep breath in, and I want you to exhale as fast as you can. Thank you.
OMG. What else can you say? Ms. Burton, first and foremost, let me, on behalf of my boss, Mr. George Lambert, who has been a blessing in my life and allowed me to take a seed that was planted in me as a child, as a light-skinned African-American child in an all-white high school with parents who were this, so I had to navigate that. It was planted in me a long time ago, didn't know where it come from, but I've been fighting ever since. I left an all-white high school and I graduated from FAMU. Then I went to Harvard. Oh, wow, I went backwards. Oh, don't put that out there. But thank you, Mr. Lambert, for allowing me the opportunity to take a seed that was planted in me as a young kid and see the fruition of the fruit, or see this fruit for the benefit of our people. Because that's what this was all about. All of these people came up here, spent their time to come for the benefit of our people, to embark upon us, to share with us information, to share their years of education, their years of expertise, their years of fighting through the system, to fighting for the truth for us. Thank you. So I had this whole little speech. My husband helped me write it because he helps me write every daggone thing I write anyway, right? But it was about America. Our brain is broken. Our brain is broken when we have a healthcare system that does not heal. Our brain is broken when our vote doesn't seem to count. Our brain is broken when history is erased. Our brain is broken when Black trauma is not in the DSM-5. So, what are we left with? We're left with the history, our culture of doing it ourselves for ourselves. So that's what I heard today in terms of conclusions. You cannot rely on a system that wasn't built for you to fix you. You can't rely on the oppressor to fix things, to fix your mental health when they're the oppressor. So we have to do it ourselves, and this is the start of it. So, I like this quote that my pastor, Dr. Johnny Ray Youngblood from Brooklyn, New York, always says, "The way out is back through." Go back and fetch it. How did we get here in the first place? We have to go back and fetch it. We also have to go back and fetch, my sister, how we learned how to heal ourselves way back in the days. So, but I don't want us to leave without knowing, okay, here's what my note said. It said, it's on us to be woke. It's on us to be woke. Don't take this knowledge and not do something with it. Don't take this knowledge and not share it. It's on us to be woke, right? So here's what we got to be woke for. We got to be woke to promote parity. Well, how are we going to get parity if we don't vote at the state legislature level? I got that. Got it. How are we going to stay woke and be woke if we don't stand up to be counted? The Greater Washington Urban League, again, because of the leadership of Mr. Lambert, is going to be a complete count committee in D.C. to make sure we are counted, and Ward 7, Ward 8, Ward 5, Ward 1 get counted, because that's where they decide who gets the money. I heard we need to be better consumers. But if we're going to be better consumers, we better face our own trauma, and we better give it voice. Our voice. If you ain't speaking about it, somebody else is in their vernacular, not ours. All right? I heard we need to build our own villages of hope. Right? That we need to promote self-healing using what we already know to do, culturally competent, Black culturally competent. And we need to have some pull-up pounds to pull us up. Because sometimes you're in your own depression and in your own self. You can't pull yourself out. Get your pull-up pound. Get your wise counsel together. But ultimately, it is about partnering, because even the Greater Washington Urban League by itself, even as big as Kaiser Permanente is, even as big as the APA is, nobody can do it by themselves. We must demand and create an ecosystem that is integrated. We must partner with our healthcare folks. We must partner with our nonprofit. We must partner with our medical profession if we are going to make a difference in the lives of African American children. So, what do we do? For the panelists, you are not relieved. You are asked to stick around so that Ms. Burton can give us our challenge for what's the next step. For the rest of you, you have their names. You know their institutions. We have this broadcast. We will be, Charles, we're going to be recycling this. It's going to be available. The information is going to be available. But find the resources. Find your place, your church, your community service organization. Go to your, where do we go for healthcare? It's primary consumer, but it's your, the person within that they want to talk to about HR, but I'm saying the people with inside your healthcare that talks to the consumers. Your advocates.
Patient advocates.
Patient advocacy. Sorry, I got all that. Patient advocate. Don't stop. If all we do is listen and write notes and we don't do anything about it and take it, then it will be for naught. These folks didn't come here for naught. We aren't here giving this information out for naught. Please find an organization to share this information with, be a part of, and if nothing else, vote. Thank you very much.
Thanks, everyone. Thank you for coming out. Appreciate this. That wraps this session. For more conversation, social media conversation, hashtag CBCF Health, also hashtag Black Mental Health. We'll continue the conversation at GWUL 365. Thank you so much. Have a great and safe remainder of your day.